Hello. Good morning, everyone. Uh, I'll welcome you all for the finals of this video session. When the going gets tough, the tough get going. And I'll request our judges to please take the seats. Dr. Minu Mathin, Dr. Naren Shetty, Dr. Rohit Om Prakash, Dr. Kumar and others will be joining soon, please. Rohit sir? Yeah, please sir. So on Friday we had prelims and uh, 8 surgeons were selected for this finals, and as we mentioned that the video has to be different than what you showed in prelims, and I hope you all have uploaded different video, otherwise you can just upload the video. So if we have Dr. Rakshit Rajgopal, I can see, yeah, your video is uploaded, yeah. So I think we can start with Dr. Rakshit with his presentation. Yeah, first intro video please, yes. So this is the 50th season of this video symposium, and we are extremely thankful to our honorable judges who spent almost 2.5 hours that day also, and thankful to Dr. Rohit Prakash sir also for including this session in his amazing winter IRSI meeting. For many years we have been doing in that meeting also. Can we have on the main screen? Yes. Our judges are our backbone of our entire program because they discuss the case, they are the experts in the field, they are some of the toughest surgeons I know in India, and it's always important to have good discussion based on the case. So thank you so much to our judges once again, and I'll request Dr. Rakshit to come forward and present his case. So 4 minutes of timer, please.
Good morning, everyone. So I think my video runs to 4 minutes, so I will just start off with the video directly.
Hello, my name is Rakshit, and this is a case of a 43-year-old case. Hello, my name is Rakshit, and this is a case of a 43-year-old high myopic diabetic with an intumescent cataract and a moderately dilated pupil. We start off with 2 paracenteses and stain the anterior lens capsule with trypan blue dye. After OVD injection, the anterior lens capsule is punctured and the egressing milky cortex is aspirated by a 27-gauge cannula mounted on an empty 2cc syringe. The plan here is to perform an initial microrhexis and a microforceps is used to achieve this. Once this is done, we switch to bimanual irrigation aspiration handpieces to clear out some of the intumescent cortex. HPMC is used to achieve a fair degree of viscometriasis, and the small capsular rhexis can be enlarged by a tangential nick and propagated by forceps. I switch to my non-dominant hand momentarily as the deep chamber makes instrumentation in the superior aspect a little challenging. Nevertheless, a successful continuous curvilinear capsular rhexis is achieved. A temporal clear corneal incision is constructed and a short central groove is sculpted into the nucleus with a phaco probe. Buzzing in to the distal end of the trench, a pre-terminal chop is attempted and is partially achieved. Progressing further with nucleotomy is made quite challenging by progressive pupillary constriction. Tentative phaco chops due to suboptimal visualization do little to cleave the posterior plate, and we try to break off bits of nucleus and emulsify them piecemeal. We continue to pull the free pieces to the pupillary plane and continue phacoemulsification in a controlled manner, but it is at this stage that we notice radiating star folds on the posterior capsule inferonasally. Something is wrong, and we need to get a better view to see what's going on. Are now used to retract the iris at the 2, 4, 8 and 10 o'clock positions, taking care not to hook the used to retract the iris at the 2, 4, 8 and 10 o'clock positions, taking care not to
Lost the video on my screen.
and 10 o'clock positions, taking care.
Okay. Sorry
Hello,
about that.
and 10 o'clock is what's going on. Iris hooks, which should have probably been used earlier, are now used to retract the iris at the 2, 4, 8, and 10 o'clock positions, taking care not to hook the rhexis margin at any point. Our suspicions of a PCR are confirmed by the presence of OVD behind the PC, and we need to get these nuclear fragments out of the way to prevent them from dropping into the vitreous cavity and to assess the size of the PCR. With the fragments now out of the way, bimanual automated anterior vitrectomy is performed. The endpoint is reached when the PCR edges are undistorted. OVD goes in before the irrigation handpiece comes out. The main incision is slightly enlarged to accommodate for a 3-piece IOL, which is very carefully nudged into the ciliary sulcus, both the leading and the trailing haptics. The remnant nuclear fragment is also brought in front of the IOL, and then controlled phacoemulsification is performed employing the IOL scaffold technique. Once this is performed, OVD is injected behind the IOL into the PC defect to essentially prevent vitreous prolapse during the next step, which is bimanual cortical cleanup of the bag. This is performed in a controlled manner, and a tiny fragment, which is found beneath the superior iris here, is also aspirated by the aspiration handpiece itself. It is now time to perform an optic capture of the IOL by pushing the optic behind the rhexis margin, first inferiorly, then superiorly, and the temporal part of the optic as well. Successful capture is inferred from ovalization of the rhexis. The iris hooks can then be removed while the anterior chamber is maintained by the air bubble and the main wound is sutured. The case can be successfully closed. On post-operative day 1, we see grade 1 stride keratopathy, a stable IOL, and a round pupil. A detailed dilated fundus exam will be performed at 1 week post-op. Thank you for your patient listening.
Dr. Suvira, yeah.
So I just one doubt.
Yes, ma'am.
You were quite brave to do the vitrectomy with the fragments still there.
Yes.
Now you've noticed a PCR. You have enough fragments which you've got out into the AC. Do you think, since you used IOL scaffold anyway, I think you did, right? You put in IOL and then removed the fragments after
That's
that.
right.
Do you think it might have been safer to put in an IOL in the ciliary sulcus and then manage the fragments and the vitreous at the same time?
Possibly, yes. I mean, when we did, I thought the PCR size was a little small, and I got these hard fragments which were large above the iris plane. Then I thought I could just get some vitreous out of the way before I tried to put the IOL, because I didn't want to have the IOL in if there were vitreous strands.
And dragging into the
And then
vitreous.
dragging the
So
vitreous
perhaps
strands
it
along.
was the smallness of the size of
Yes,
the PCR.
essentially
If it was
having
a
that-
large PCR,
I wouldn't
even
have done
I would
that.
be scared to
Absolutely.
do a
I would
vitrectomy of the fear that the
drop
fragments.
pieces, yes,
And
for
therefore, in
certainly.
a case like that, to prevent a drop, even if required, I would enlarge the incision
Yes.
and do viscoexpression of the
Agreed.
fragments.
I would have done that.
I understand.
Thank you.
Thank you.
Thank you, ma'am.
Well managed.
Thank you so much.
Just a thought process. You think you could have avoided a PCR in this case by doing one step before
Certainly.
it happened?
Definitely, sir. If I had just placed the hooks in the beginning, then I wouldn't have had the PCR.
So I thought that was the only
Yeah,
difference. I mean, or using epitrate or adrenaline may have helped
Agreed.
you. Was this a male patient?
This was a male diabetic
prostate?
patient. No BBH.
prostate.
It was a younger male. In fact, the grade of he was a newly diagnosed diabetic.
Correct.
So the cataract was intumescent on table, whereas it wasn't a couple of weeks when I saw him in the OPD. So I thought I could manage that. I mean, usually I have a very low threshold for hooks. I put them instantly because I'm more comfortable. This is one of those situations I didn't, and I got a video out of it.
If you have done this at this age, I think you have mastered this technique well. Congratulations.
Thank you so much,
And
sir.
that,
Thanks so
and
much,
you
sir.
have admitted that one thing which I wanted to tell was putting the hook when the pupil starts come down. You have admitted that that's also a good trait. Thank you.
Thank you, sir. Thanks. Thank you so much.
Thank you so much, Dr. Rakshit. So before we move on to the second presenter, let me announce that for the winners, we have we have a trophy and a hard disk drive as a gift, and for runner-up also, and 2 second runner-up. So judges have to select 4, We have to give 4 awards, and all 4 get the trophy and hard disk drive of 1 TB, sponsored by Micro Labs, and thanks to Epsilon also. All the finalists are getting Epsilon instrument. Those viscoelastic and hydrostitch cannula are my design cannula. So thanks to Shyamji for giving those to all the finalists who have reached here, and the winner gets 25,000 rupees certificate from voucher from Epsilon. They can get instrument from their booth. Runner-up gets 20,000, and two second runner-up get 15,000 voucher each. So thanks to our sponsor for supporting this program. Thank you so much. So next is we have Dr. Oshivarya Chakravarti with her case. Dr. Siddharth, are you also ready? Yeah, after her, yeah.
A very good morning, everyone. I'll be presenting my video right now.
4 pathologies, 1 eye, and 0 margin for error. This video demonstrates the surgical management of a complex cataract in a previously vitrectomized eye
Volume up, please.
who presented with an intumescent cataract, posterior synecdoche, prior radial keratotomy incisions, and silicone oil in the anterior chamber. Conjunctival peritomy and cautery was done, followed by creation of a tunnel of 2.5 to 3 mm length was made between the radial scars. Following this, entry into the anterior chamber was done and silicone oil was removed from the anterior chamber. The capsule was stained with trypan blue, but the oil kept coming from the posterior segment. 2 side ports were made and posterior synecdoche was released. We dilated the pupil to enhance our field of view with a 7 mm malusion ring. The capsule was restained, but despite that, it didn't stain well. Managing the rhexis was the next big challenge. As this was an intumescent cataract, we used a bent cystotome to puncture the capsule and rotate the flap with 23 gauge microrhexis forceps. The difficult part was to rotate the flap where the capsule was stained less. However, we could complete the rhexis, but the size achieved was small. Gentle hydrodelineation was done, and the nucleus was gently rotated. We decided to proceed with phacoemulsification, but with a reduced bottle height. Vacuum and aspiration flow rate were lower to perform a slow motion phacoemulsification. Once a small piece was removed, it made it easier to emulsify the other pieces as well. Bimanual irrigation and aspiration of the cortical matter was done. Full retroillumination mode was used in the microscope to improve visualization, followed by insertion of foldable hydrophobic single piece intraocular lens in the back. Malusion ring was removed. And further removal of viscoelastic substance was done. despite removal of the viscoelastic substance, the silicone oil bubble were still entering into the anterior chamber, where we finally realized to put viscoelastic substance more and seal the anterior chamber by suturing it so as to proceed with the silicone oil removal done by the retina surgeon.
This was silicone oil removal was planned immediately or
Immediately.
immediately. So then it doesn't matter. But staining part, I would do by releasing the posterior synechiae first with sodium hyaluronate inside, and then some saline on top of the capsule, and then stain. Then it will give you a better uniform staining. Okay. And scleral incision for these kind of cases, 2.2 or 2.4 was already there in between. It was only a 16 cut, I think. So there was space to create a clear corneal. If there is space to put a clear corneal, you can put a clear corneal. Scleral means scleral, not to this much into the cornea. That doesn't make sense. To make a scleral is to avoid the corneal cuts. So that means you remain scleral just into the limbus. If you go this much into the clear cornea, it means it's a clear corneal incision. It doesn't matter whether you make a scleral cut or not. Okay. Otherwise, well done.
Thank you.
Very well managed.
Thank you.
I quite like the fact that you went scleral, because we've seen, even I've seen myself, sometimes you get these post-RKIs which are such deep cuts that even if they are widely spaced, there is a potential, if you go clear corneal, to just disrupt them, and then you're left with, rips in the cornea which then need to be managed.
Exactly.
And also, despite having a 4 or 5 millimeter pupil, you chose to dilate it further. I agree with Minu that staining the anterior capsule, even if it takes time, even if it takes more than one injection, should be done, because it gives you that visibility and that support. If I had to pick only one flaw, is that you did the second half of the rexus through the main incision itself.
Yes.
Where you had a lot of viscoelastic coming out. And so you have to train your non-dominant left hand to also do it, because in an intermittent cataract, above all, you need to have a stable, well-formed chamber with a flattened anterior capsule to ascertain the likelihood of you getting your rexus bang on. But otherwise, extremely well done.
Thank you, ma'am.
I think wonderful case. I would just say, especially in RK, it's it's good to see where, before the surgery itself, where will you place your main port and side ports. So I was just trying to see the place where you place the main port. The space was very less between the two cuts. But actually, if you look at the video again, at 10 o'clock, there's one area which was quite wide enough where you could have placed the main port very safely between the cuts. Okay. So those things we should not normally miss out. I would say that is one. The second thing is, when you finish your case, it's good to keep your irrigation on. You should, while your irrigation on, hydrate your side ports and main ports, and then come out. Because when you have a oil, every time the chamber collapses, oil will keep coming up. So the key is to hydrate majority of the ports, and this one, the last port, will be much easier, so that reduces the chance of the oil coming
into the antechamber. Okay. Thank you, sir.
Excellent surgery. Just one comment on the editing, that you should crop the video, because if you see the initial procedure, only the 25% of the entire screen was, eye, rest of it. So it makes the presentation even better.
Okay.
Very well.
Thank you.
Did you do hydrodissection also?
Hydrodissection, no, it was mainly hydrodelineation.
Hydrodelineation in such a white.
We tried to do hydrodissection as well, but it was not done. We could not achieve that well, because the rexus was also very small.
I think basically, whenever I think you should make it a rule of the thumb that whenever you cannot see a posterior capsule, you should not do hydrodissection, because there can be a pre-existing PCR, and when vitrectomy and everything has been done, there may be some injury to the posterior capsule as such. So that is really something which one should try to avoid under all conditions.
Okay, sir.
Yeah. Otherwise, I think it was absolutely nicely done.
Very well managed. I was just thinking, did you need a Malugan ring?
Yeah.
Yes, sir. Yes, sir.
So that's one thought. I'm just talking aloud. Yeah. And another this question is to the panelists. Have you all put an endocapsular ring in such cases to prevent the oil from coming out. Does it help?
Not really tried. Not tried. Have you tried?
So he's saying it doesn't help, but
What is
I've-
your experience?
it occasionally helps because it stretches the bag and any oil that's coming out from the zonular area stops. But I don't know.
Could you have removed the oil at the same time of the surgery? Prashant, you're here.
We did-
At the same time.
It was planned to be removed at the same time. The retina guy thought we'd ask to finish the cataract first.
So they had more visibility.
Yeah, so
that
it was
makes
already planned at the same time.
So in that case,
And the
CCC is the only thing
hydrodissection
important thing you
was
have.
not done
Yeah.
in the invasive hydrodissection.
Sorry?
You didn't do a proper hydrodissection which was exactly for the reasons that you had mentioned.
Perfect. Yeah.
Okay,
Thank you,
you,
ma'am.
Ashwara. Okay, next we are calling Dr. Himani Chatterjee. She has another presentation. Judges to note, it is the last thing on the first page. Last name on the first page.
I have an IC right now, so I'll just speak first.
Sorry?
I have an IC going on right now. So I'll
That's
just
okay, you
speak
can
So
go
yeah,
ahead.
please go ahead.
Thanks. 101. Curtainless videos is what I call it. A 45-year-old female presented to us with bilateral congenital aniridia with severe ptosis, nystagmus and mature cataracts. On examination, her vision was PL plus and PR accurate in both the eyes. Her son also had a similar history but without the cataract, of course. So I reviewed literature and found that aniridia with cataract is actually a very rare entity, and posterior lenticonus being 0.08% cases. So there were multiple challenges in a complex anti-segment anomaly. So let us walk through how I managed the cases. The first problem was the increased peripheral corneal thickness, which made it difficult for the side port incision. Also, the AC was very shallow because of the thickened lenticular thickness. Poorly stained capsule, weak zonules, these added to the complication. I tried doing the capsular rhexis, but the capsule was very thin and it was making it very difficult for the capsular rhexis. Also, there was no space for the micro rhexis to enter, so I converted to a can opener capsulotomy. And planned to proceed with SICS because cornea and zonules were very unhealthy. Made a sclerocorneal tunnel. After the cortical wash, I realized there's a small calcified opacity in the center, which could have been a posterior lenticonus pre-existing. Then I placed aniridia ring segments. The second one was trying to go to the sulcus, so I gently maneuvered it with the Sinski hook. Placed an IOL in the back. So post-op day 1, she got a vision of 3 by 60, and the patient was very happy because from mere perception, and she was able to see the world again. Thank you.
I think excellently managed. When in doubt, convert, which you did, because you were not able to, really appreciate the anterior capsule. Wise decision at that point of time, in taking that. Other than that, I don't know whether you all have tried that. We published it way back in 2000, whatever it is, 17, 18. You put air in the anterior chamber and then through 30 gauge needle from the side port. Because the basic concept involved is you need to have a stable, what should I say, hold on the anterior capsule of the trypan blue. But with air, what happens is that it comes out, you're not able to have it. But the way he said with the shell technique, that does help. But with modified 30 gauge technique, which we do, we just paint the anterior capsule under air with hold time of 20 seconds. That does help at times. But I really appreciate the way you did it.
Yeah, aniridia is a very rare case and has to be tackled very carefully because of the associated problems. Like most of them are faced with glaucoma.
Yes, sir.
Because even if we say it's aniridia, usually there is a iris stump which is around. So if you place anything in the sulcus, it's going to exaggerate the problem of glaucoma.
Yes, sir.
Also, they have limbus stem cell deficiency. So you have to be very careful whenever you are going closer to the limbus. Like in SICS, you did right because I hope you have not done much of cautery there.
No, sir.
There is a high chance that the pannus will start from
Yes,
that
sir.
area.
Yes, sir. She already had 360-degree pannus.
Pannus, yeah,
Yes.
that's usually what we see. And one thing I would like to say is that it was planned earlier that you will put the aniridia rings.
Yes, sir.
So if there was no capsular axis, if you put aniridia rings, usually it will travel to the sulcus because there is no anterocapsular support.
Yes,
so it
sir.
might increase the problem. And if you see the aniridia rings, it hardly cuts off the light
Yes,
generally.
yes,
And these patients are already tuned for those glares.
For
and
her
halo.
the second eye, I did not place aniridia rings
Yeah.
because then I realized that she already has ptosis. And she was quite happy with the ptosis. She did not want
And
the ptosis surgery.
they have foveal hypoplasia also.
Foveal
So
hypoplasia as well.
actually, most of the time the glares halos is our concept. They are already
Yes.
used to that,
Used
or
to
their
it.
retina is already. If there was a chance, I would have put a aniridia IOL because you are already enlarged. Of course, it has to be pre-planned. You have
Yes,
to
sir.
order it.
Yes, sir.
But what would I have done? I would have done an aniridia IOL, but scleral fixate it on both sides so that it doesn't move in the eye.
Yes.
So anything in sulcus, the glaucoma is going to rapidly increase in this case. But very well managed. It's a tough case to even think of taking on.
Thank you, sir.
Do you think if you had stained the capsule properly?
Ma'am, I stained the capsule twice. Trust me. I stained the capsule for 30 seconds first because it was already a mature cataract. I washed it off and I saw it's not stained yet. I stained it again. And then for 30 more seconds I stained it. Still it was not stained yet.
So I think it's an embryonic problem, ectodermal problem.
Yes, sir.
Even
Yes,
the
sir.
lens is not what we see in normal patients.
And what do you think the reason is for the capsule not staining?
Probably that's the thing, that ectodermal problem. So
The
everything is
lens
associated. Probably the
epithelial
lens
cells,
capsule
I think.
doesn't have the same consistency or histopathology like a normal capsule.
But without
might be
collagen,
the-
you cannot have a capsule, and if
Not
there is
under it.
collagen, it
First
will
time
stain.
I just
So,
did normal staining, and second time I did it under
But
air.
as you said, you should have put maybe more efforts to
Yeah,
stain
yeah.
it.
So that is one thing. And one thing about your tunnel, if there is no iris, you will think that the lens is very big. If the iris is there, you won't think that it is big. But the nucleus was not so very big to have a tunnel so big. This is such a huge tunnel. Good that you have made it well.
I just
But
I
titrate
was
according to the
planning a
view.
safe surgery, so that's
Yeah. Safety is very important. But you should assess the size of the nucleus, and then that is the general policy. And without a capsular access, as he said, this aniridia rings are on a long term problematic. Can be problematic, but you have placed them very well without breaking them. That's a very, very fine, subtle way of doing it. Very nice, because it easily breaks off. And both you have placed without breaking. Good, very good. And again, a single piece foldable after a can opener in the sulcus. Again, underneath the aniridia ring. Again, all this crowding happens in the angle, and finally, these people, the glaucoma part, and later on they'll come back to you. You are quite young. They'll come back to you after 5 years, 7 years. Then you'll have to manage. Anyway, good.
This was my first aniridia ring placement, sir.
You could have also used an aniridia IOL in the sulcus, right?
But you have to scleral fix. I have done it couple of times, but you have to scleral fix.
Otherwise, it should be in the bag. The large rexes in the bag, or in the sulcus, fix it in.
Which company dye did you use?
Sir, sir, Appa.
Use the same company.
Okay, great.
Thank you, sir.
Okay, next I call upon Dr. Nilesh Kumar. Dr. Nilesh has a presentation in another session.
I'm really sorry to come in between, but I have one more commitment, so sorry for that. I'll just play my video. Good afternoon, good morning, everyone, all the judges and to the audience. This is a case of hypermature white cataract. Intimations is there with brown nucleus, and this was my first trifocal case, a paying patient. Of course, I did others, but I was not having that onus at that time. I started with the capsular eye running, and after the capsular eye running, I started with rexus, and suddenly the rexus ran off. So even after the eye running and decompression, and that was my first mistake. I just slipped it and then started and continued to it, and that was at the place where the main port was, and again the iris started to collapse. It was an IFIS case. So I start with the trench. The nucleus is moving really fine, and I complete the trench, and then I thought that I'll just do a lateral separation. Second mistake from my end, because that was again in the same direction where the extension was, and suddenly I noticed that everything stops moving, and I take it out, and then when I see that the extension has run beyond. Thanks to I really want to say about sir, that sir has told about that there is a flutter sign where you see if the PC that is extending has ruptured behind if it is not fluttering, the entry vitreous phase is intact. So now I stop at that time. I realize that okay, there is that PC that has gone, the extension has gone behind. I go really slow. I'm just assessing, and you can see just from behind, you can see that triangle of extension. So again, third mistake, that I took the Phaco probe out before putting the visco in. So it gave rise to more thing. But I am a fan of IOL scaffolding unless and until the vitreous is disturbed. So the same trifocal went inside. It went because the other capsular support was good, so I thought that it will remain stable because the vitreous phase is there. I put it inside, dialed it into the bag, and what I did is how we protect PC with the chopper. It is protecting the trifocal lens so it doesn't damage the optics, and I take it out. Now after taking it out, I see that there is a big piece of cortex that is behind, and again that is the problem. But I have learned from my mistake. I don't decompress. I do a visco exchange. Again, the fluid starts to the iris starts to prolapse. So I thought that I'll leave the case over here, close it, suture it, and then probably do a capsulotomy later. But again, there is a tendency for the first timers to give perfect vision in any case they want to do, and we end up messing the case. So I thought that okay, let me be very cautious. I'll just try to see if I can move that cortex out. If it happens, it's okay. Otherwise, I'll leave it. That was I was mentally prepared for that. But when I see that the IOL was very stable, I don't have to do much of things. So what I thought is I'll go behind the IOL and try to wash it off. So the PC rent was not extending. I just did it gently. It was not extending. I tried to go behind to irrigate it out, but it was not getting irrigated. So I thought that okay, I'll just go with the suction and try to gently pull it out. So with that I could do. I just lifted the IOL from one end and did it out, and luckily it came. It is not like it might have gone the other way also, but the patient ended up with a good thing. Again, I did the fluid air exchange before closing the case, and I'll just show you. The patient is with me 6 months post follow-up. The other I have done other case. She came with again intimation cataract, but in that luckily everything went good. You can
Generate
see
by AI.
At 6 months it is completely central. The patient is having 6/6 and 6 vision.
So one point I'd like to make. When you see iris prolapsing out of the main incision, sometimes you have floppy irises that do prolapse because your main incision was pretty good. it's prolapsed so many times because once it prolapses, the tendency to
Yes.
prolapse
Yeah.
remains. So it may not be a bad idea to, if you want to continue with the same incision, use a little bit of dispersive viscoelastic just over the iris that pushes it down and maintains it there. Sometimes people make a subincisional incision and put in a hook to just hold on to the iris there. What I would probably do is close down or hydrate that incision, make a new incision and start. But that might change your SI and things
Yes.
like that.
So I did use viscodispersive, ma'am, because I always, whenever there is a PCR, I coat that PCR with a viscodispersive agent. So I used it below, over the iris, as well as went behind the remaining heminucleus that was there and dispersed the visco coating over that also before still it was coming.
Could use a
So
hook under that
yeah,
incision or probably make another
I'm not a fan of hook, ma'am, because it tends the iris at that place, and again
make a very posterior postlimbal incision, it might.
No, she is trying to make points which would be differently managed. Not that it's finding
No, no,
fault
sir,
with you,
I
or
completely
you
agree,
are
sir.
not
I'm
a
just-
fan of hook is not the question.
iris
It is the way, in
prolapse
different
from
ways,
happening
people
more.
manage it.
Yes,
This is
sir,
what
yes.
she is mentioning. Okay.
So, sir, ma'am, just to add on, what I use in cases of iris prolapse now, it was not available at that time when I was doing this case, is B-octa. With B-octa, I am getting a 8.75 or 9 mm dilatation. So that iris that is prolapsing goes below the incision, and the iris also doesn't tent up. So right now, in any case of IFS, now I have started using B-octa.
And no visco. How are you sure that the IOL went in the bag with that half that nucleus there?
I didn't show it, ma'am, because it was only 4 minutes.
You
But
did
with a
check
Y
it,
with a Y crutch, I just retracted and completely checked it.
I could imagine the heart rate you had during this surgery.
Yes, sir.
But I think one of the things is when you are trying to use the scaffold, the pupil had come down already.
Yes, sir.
So, it was better if you were anyway going to put the single piece. It was better that if you put iris hooks to, dilate the pupil fully, and under visualization if you put it, rather than going little bit blind. Of course, you checked it later, but it can sometimes directly go into the vitreous cavity.
vitreous, yes, sir.
So just dilate it completely so that you have complete view of the bag, and then you can gently place it.
Will do, sir. From next time.
You said this was your first trifocal?
Yes, sir.
In a hypermetro cataract without optical biometry?
No, sir. Luckily, there was little bit of intuition, so optical. It was IOL master reading only. Then only we proceeded with that. But the patient was very adamant. She is a deputy mayor of our area, and I don't know how she was working with this eye, but she insisted that she wanted a trifocal.
That means she's not working.
Okay, I would land this IOL as a scaffold. I would land it in the anterior chamber to be safest, because the anterior capsule is broken, posterior capsule is broken. To complete the phaco, I would land it in the anterior chamber, and then I, like you said, put hooks and then visualize. And if possible, only I'll place this single piece lens in an axis which is opposite to the area of PCRN. When iris prolapses like this, iris is not something which will prolapse on its own. It is not its wish to come out. It is we who are making it to prolapse, because patient by whatever. And if you stop irrigation and wait for 1 second before taking out your irrigating probe, many iris tissues don't follow you. That is one thing which we have noted. And trenching so much after having a capsule extension away from your incision is dangerous, and so I would pick the nucleus out of the bag partially and chop outside the bag so that there is no stretch on the bag. These are the things which I would have done differently in this.
Yes.
So one of the things which
I think
just as a beginner we always face. I mean, those who have not would say that they have not faced probably have low memory. Okay, the one thing which we see on video analysis is like how desperate we are to complete that case, and that you can see when you are chopping and doing. So in ophthalmology or surgery, the rule is that whenever you are desperate to do a certain step, you are doing something wrong, because in the ophthalmic surgery, I think every step can be well choreographed.
Yes.
So whenever you have such difficulty and you are feeling desperate to certain, just take a pause and think how you can do.
Yes.
I think it was one of the boldest surgeries I have seen for a long time. I can tell you that, because starting from first step, when it was an intumescent cataract, you were trying to complete the rexus to the main incision. So there was aggression of, visco. And I think, which visco did you use?
It was a soft cell technique, sir, visco-dispersive and visco-cohesive.
Yeah, and that led to the, extension. And then, rightly said, ideally, you should not have done, you should have done it supra, capsular. It should not be done. And if the chopping has to be done, it has to be a horizontal chopping, but not in this case. And the separational forces also you should not rotate the nucleus in the bag. For all, and make it a rule of the thumb, whenever you have an anterior capsular tear, it's always better not to rotate the nucleus. And the separational forces have also to be, if you think of doing it in the bag, which I suppose should not have been done. And then, irrigation off is something which is the, concept. And putting a trifocal with, with a young patient who happens to be a mayor or something like that, you want to have the IOL centered throughout. And I'm not sure whether in the long term it will remain like that or not. So it's always, I feel, better to say no at one stage than, because you have to see the long term, keeping that in mind, I would at least not have gone in for a trifocal by any means.
I think luckily mayors get transferred every
day.
But
I think just one comment I would say is, very difficult. Sometimes, we have those cases where you back-to-back things keep going wrong. Just a small tip is, like everyone was saying, putting specifically just below the incision viscoat, only in that area, and then filling up is one way. And every time you bring out your phaco probe, it's the speed at which you bring it out. When you bring it out with a very fast speed, it creates a suction, so any content comes out more faster. Yeah, yes, sir. So the whole point is switch it off, your irrigation. If you want to be even more precautious, take your dialer, go just below your incision onto the iris, and then slowly just take it out. So you're rest assured that every time, if it has a tendency, it's better to be a little more overcautious so that you're rest assured that the iris doesn't come out. So I think otherwise, I think you have wonderfully accepted a lot of the things which you have done. I think fantastic. Thank you.
Thank you so much, sir. Thank you. Thank you for the tips also.
Okay. Next we have Dr. Siddharth Ghosh.
Good morning. I am going to. Right. Okay. It's not coming.
Late spontaneous rupture of the posterior capsule. A 52-year-old male presented with sudden dimness of vision in his left eye. He had history of undergoing uneventful cataract surgery in both eyes 14 years ago. There was no history of trauma or NDR capsulotomy. On examination, the best corrected visual acuity in his right eye was 6/9 and N6, and in the left eye it was 6/24 N36. Slit lamp examination revealed a well-centered multifocal IOL in the right eye, whereas in the left eye there was a posterior capsular tear and PC IOL was dangling in the vitreous cavity. For management of this case, relocation of the existing IOL in the sulcus was planned, as multi-piece multifocal IOLs are not available in our country. Pars plana vitrectomy was done to remove as much vitreous as possible from around the IOL to make it freely mobile. A 2.8 mm incision was then made, and the superior haptic of the IOL was brought into the anterior chamber, supported over the iris, and then gently manipulated to place it in the sulcus. After that, the optic of the IOL was held firmly and gradually lifted up and placed over the rim of the anterior capsule. Thereafter, the inferior haptic was brought into the anterior chamber, supported on the iris, and then, after removing a strand of vitreous, it was gently manipulated to be placed in the sulcus. Stability of the IOL was assessed and optic capture was made. A single suture was taken to ensure stability of the anterior chamber and to avoid further iris prolapse. Thereafter, pars plana vitrectomy was completed to avoid any long-term complications. Wound closure by corneal hydration was achieved. 1 month later, he maintained an unaided vision of 6/9 and N6 in his left eye. Since late spontaneous rupture of posterior capsule with IOL dislocation is a relatively rare complication and only a few cases have been reported, it was interesting to look at the published literature where various possible causes have been postulated.
This was actually a dead back syndrome, and this patient 14 years ago, I only operated on both eyes and it was accuracy restored. So he did not want to part with the binocular and good multifocality he enjoyed. We explained that it's going to cause problem if we put it in the sulcus, a single piece. He said, okay, I can come back for another surgery if you wish. We initially planned with a monofocal multipiece. So, but he insisted now it's about 2 years, 2 months follow-up, and he's doing fine. Touch wood, no complications as of now.
Very nice, sir. I think I was just thinking that what about the reverse optic capture, sir? Keeping the haptics in the thing.
Exactly. Initially I thought, but then I thought if the zonules give away because it's a dead bag, at some point of time, then the whole thing will sink.
Anyway, he's ready for second.
Yeah, that's true.
So if you're keeping something,
That's
it's
true.
better to put like a safer option. Then later, if you're planning to do, might as well. I mean, ideally, it's better to do a scleral fixation. Yeah. So it's much better.
In these cases, my experience has been that you should not use sulcus if you want to have long-term outcomes. But of course, here maybe as you said, patient and was so even if it stays for 1 or 2 years, it's fine, because I have even used earlier 3-piece IOLs in the sulcus with these, and they also dislocate because the entire bag kind of goes away. So best way for long term might be a scleral fixation, which I think as a retina surgeon you are very well versed.
But if he has a multifocal in his other eye, correct, am I right?
Yeah, exactly.
So he still has multifocality. We have seen a lot of patients with a monofocal in one eye and a multifocal in the other eye. Perhaps in a court of law this would be safer.
I think it's excellently done, but for the audience, not for you. I would never suggest you put a single piece in the sulcus. The ERG syndrome, I would never advocate that. And for the audience, never put a sulcus, in the sulcus, a single piece IOL. Surgery well done, but then if you are a posterior segment surgeon, so you may not be fully into the intricacies of the anterior segment surgeon. Surgery was excellently done, but putting a single piece IOL in the sulcus should be definitely avoided.
One point noted is the iris prolapse through the main incision. Did you have the infusion on all the time?
No. At that point of time,
if so, infusion should be, when you're manipulating in the anterior chamber, infusion should be switched off and fill the anterior chamber with viscoelastic and then manage. If it becomes soft because of leak through something, maybe you can switch on and off occasionally. But otherwise, this will happen.
Thank you.
Thank you. Next, we have Dr. Prashant Ranganath. For the judges, it's on page 2 first.
Determination, hard work, and a thorough preparation is what we need to conquer even the tallest mountain in the world. Anterior anterior lenticonus is most commonly associated with Alport syndrome, which can be X-linked or autosomal recessive. Other associations are kidney diseases, sensory neural hearing loss, and ocular disorders like dot and fleck retinopathy and retinal thinning. This is a case of a 45-year-old male who came with mature cataract and anterior lenticonus. A clear corneal temporal incision was made. The capsule was stained with trypan blue dye. And now comes the most crucial part of the surgery, capsulorhexis. The surgeon here tries to decapitate the cone from the base, and with gentle maneuvers, he is successful in doing so. Now what we see is a nightmare to the cataract surgeons, an irregular capsular opening. One mistake and this rhexis would run behind. The aim is to make this a stable and a strong capsulotomy. With the help of scissors, one end is cut, and with the rhexis holding forceps, carefully a larger rhexis is made away from the base of cone. As they say, good capsulorhexis is half the work done. We emphasize on gentle hydrodissection so as to give very less pressure on the capsule. A full and free rotation of the nucleus is ensured before proceeding with phacoemulsification. Gradually and carefully, multiple chops are done and the nucleus is divided into several fragments, which are then emulsified. A gentle cortical matter aspiration was done, taking care of the fragile ends of the capsule. And finally, the intraocular lens was successfully implanted in the back.
Actually, he was a one-eyed patient. Other eye also he had a spontaneous rupture of the capsule and an anterior submental dislocation of the nucleus, which he had with the corneal decomposition, he lost it completely, and he was mentally retarded. We had sent him to the nephrologist to get into to look in for an hereditary nephropathy or nephritis, which can happen with Alport syndrome, which is common. Thankfully, they gave a clearance after 3 to 4 weeks. We have taken the patient. Thankfully, he got just around 660 vision, and something which is ambulatory for him. And he was very happy. He keeps coming back every 6 months to follow up with us. Thank you.
So next we call, do we have any discussion points? Okay. Yeah. Next we call Dr. Gaurav Pandey. Dr. Varsha is here.
Case 1 presents with 4 clock hours of zonular dehiscence and generalized zonular weakness. The hazy graft-host interface often compromises visualization making capsular access particularly difficult and increasing the risk of extension. In this case, a controlled capsular access was carefully fashioned using micro scissors and micro forceps to ensure precision and prevent radial tears. Given the compromised zonular support, a capsular tension ring was implanted to enhance capsular bag stability and facilitate safe intraocular lens placement, thereby optimizing surgical outcome despite the complexity. Case 2 presented with complicated anterior segment with extensive peripheral anterior synechia, first released using an iris repositor to restore anterior chamber anatomy. The presence of correctopia with small, poorly dilating pupil further compromised intraoperative visualization, hence, mechanical pupillary dilatation was achieved using iris hooks. This provided adequate exposure of the lens, improved surgical control, and enabled the procedure to be completed safely under challenging conditions. Case 3 presented with graft failure, having dense corneal vascularization which possesses extreme intraoperative difficulty due to severely compromised visualization. With virtually no clear view of the anterior capsule, posterior synechiolisis was first meticulously performed to free the pupil and improve access to the lens. Given the hazy corneal media, phacoemulsification was carried out with heightened caution and nuclear chopping was performed outside the capsular bag to enhance control and reduce stress on the zonules. The procedure required precise fluidics management and careful maneuvering to safely complete lens removal despite the markedly limited visibility. Case 4 presented with dense pupillary membrane, hence significant visual and surgical challenge as the membrane can completely obscure the underlying cataract. In this case, meticulous membranectomy was performed using micro scissors and micro forceps to carefully dissect and peel the fibrotic tissue without compromising the graft or iris. Once the adequate visualization was achieved, cataract extraction was carried out cautiously with controlled maneuvers to protect the corneal, graft and zonular integrity. In all these cases, with careful surgical planning and execution, the procedures resulted in favorable visual outcomes despite the complex presentation. I would like to thank my mentor, Dr. Yatish sir, for helping me out with these cases.
Very challenging and well done. I would perhaps consider SICS rather than a phaco if I've got like a almost failing graft, but otherwise I think they're very challenging. Well done.
Thank you.
Next we have Dr. Varsha Chauhan. That is the last presentation. Please note the videos are for 4 minutes.
A very good morning to all. Respected chairpersons, judges, and esteemed faculty. I'll be presenting a video on vitrector-assisted DSEC in a post-DALK scarred patient. Where is it not playing? It's playing here, but yeah. So in this, we have used a MVR blade, which was bent at the tip, to make multiple radial excisions on the posterior stroma. Then the fibrotic tissue was dissected carefully, and using a 20 gauge vitrector, the fibrotic scar tissue was removed. So here the multiple wedge-shaped incisions are being given. And this is the 20 gauge vitrector to carefully remove the fibrotic scar tissue. Then the donor lenticule was taken to dissect the DSEC lenticule, and using Bucin glide, and it was well opposed with the air tamponade. So I would like to sincerely acknowledge my mentor, Colonel Vijay Kumar Sharma, cornea and refractive surgeon, for his invaluable guidance and last moment support for this video. Thank you so much.
Thank you so much for this presentation. Now I'll request judges to please come forward and give away the awards. Dr. Vanashri, can you compile the result, please? So I'll request all the participants to please come here and collect the participation prize.
So the
for
all
this
the
by
finalists,
the time it's been compiled.
all the finalists have the
Not that. Come. Dr. Gaurav, yeah. Everyone please come. Take. So these are special cannulas made by Epsilon, and Nareen, Dr. Nareen, please come. Who else is there? Yeah, come, Rakshit. Do we have the results? Any trophies we have to give? Okay, I think next session has to start, and we'll take 5 minutes, and after we can give the awards. Thank you. Still have 5 minutes, don't worry. We have? Okay. Okay, sir. Thanks. Any time. It's better if we can have the result right now. 2 minutes. He said ChatGPT does it.
Okay, so we have the second runner-up being announced first. That is Dr. Aishwarya Chakraborty.
Something more. 1 TB hard drive to record your surgery.
Thank you so much.
And this is a 10,000 rupees voucher from Pepsi.
Now the first runner-up.
First runner-up is Dr. Varsha Chauhan. So this is second runner-up. Varsha Chauhan, congratulations.
The runner-up is Dr. Nilesh Kumar. He has gone to another session.
And the winner?
Winner is Dr. Can I see? Dr. Rakshit Nathan.
Make amazing videos and make it count.
And a 25,000 rupees voucher from Pepsi. Thank you so much.
All the finalists, please collect your certificates from us.
See, the judges got 32 GB and the participants got 1 terabyte.
Yes.
This is just to bring to your notice, okay?
Thank you, Shyamji. Yeah, Shyamji is here. Thank you so much. And thank you to Amitji, Microlabs, for giving away, supporting this session. Thank you so much.